Welcome to this session, Flash in the Clinic, Treatment Planning. It's my great pleasure to introduce Anthony Lomax from the Paul Scher Institute, who's going to tell us all about treatment planning for Flash. Over to you, Tony.
Thank you, Michael. So good morning, everybody. It's a great pleasure, privilege and honor to be giving this talk at the FRPT this year. Of course, like many people, it would have been very nice to be there in person. Of course, for obvious reasons, we can't be. So yes, I'm going to give a talk on treatment planning, but specifically for protons and specifically for pencil beam scanning, and also specifically in relation to Flash, which of course is the topic of this conference. I want to say that a lot of this work has been funded partially by Varian in a close collaboration with that company. So, okay, we know the Flash effect, and if you saw Marie-Catherine Vozenan's plenary talk, of course, it all started with this paper from her and Fovedon in 2014, which clearly showed a reduction of normal tissue response to radiation at high dose rates. But importantly, and as Marie-Catherine very correctly points out, that was not the new thing. The new thing in that paper was to show that the high dose rates did not have a detrimental effect on tumor. So actually, Flash could potentially open the therapeutic window, which is why it's such a exciting idea, concept, and why I guess everybody here is in this conference to see how we can bring this into the clinic. Now, of course, we're looking, and it's a high dose rate effect. And the paper from Fovedon et al. Here, they were looking at dose rates above 40 gray per second. So clearly, if we're going to do Flash in the clinic, if we're going to do Flash for patients, we need to be able to somehow include dose rate as a parameter in the treatment planning. Now, as I said, I'm going to be talking about protons and pencil beam scanning. So why are protons interesting for Flash? Well, again, in Marie-Catherine's talk before, we saw electrons are being mainly used for Flash. Photons are being considered, but also, as she mentioned, quite a lot has been done with protons for Flash irradiations. And the reasons are because with a typical proton machine, this is a cyclotron, synchrotron, whatever, you can get quite high beam intensities. This is a plot of the beam intensity we can get from our cyclotron. This is a Varian 250 MeV superconducting cyclotron. On the x-axis here is the beam intensity in numbers of protons per second. Note this is a logarithmic scale and as a function of energy. And straight from our machine, if we're using the highest energy, then actually we're already getting a continual beam at the rate of 1500 gray per second. So this is not pulsed. Of course, if you're looking at other types of machines, it would be a pulsed irradiation, but this is continual wave, but already at very, very high dose rates. And of course, this is very interesting, is will we see the Flash effect? Do we see the Flash effect with such dose rates? And as Marie-Catherine showed, yes, it has been demonstrated with protons. It's also been not demonstrated in other proton experiments. So we need to understand more about the mechanisms and also the beam characteristics. But Flash has been seen with protons. So here in this talk, I'll go back away from, let's say, the mechanistic part and actually more to how we could eventually incorporate this into the treatment planning process. So if we want to predict a Flash effect in a patient a priori, as we also want to do in treatment planning, where we're planning dose distributions, we really want to be able to calculate and display spatially varying dose rates as well. So basically, we need to take, of course, or do what we do typically with treatment planning, shown on the left here, a dose distribution planned with multiple fields in this side. But now in the treatment planning process, we need to add a different parameter. And on the right here is the spatially varying dose rate for the plan on the left. And for this, of course, we need to know the characteristics of the machine. We need to know the dynamics of the machine, etc. I'm not going to go into the details of all that, but I will just show some first results, which we did looking at trying to estimate dose rates, three-dimensionally, spatially varying dose rates in the treatment planning system. So what we did a few years ago, and this may already be old, but I just want to show you to show the concept, is we came up with this idea of something we call dose average dose rate. Now, people in the audience who are familiar with linear energy transfer, LET, you'll know this concept, dose averaged LET. We took the same one, dose average dose rate. So we can calculate the average dose rate in the voxel with each contribution being weighted by the dose of that pencil beam. So this was the equation in the paper, which was published by Stephen van der Water, who will actually be talking in the next session, in Acta Oncologica in 2019. This is the equation. I'm not going to go into details. But of course, for this, we need to have an estimate of the beam intensity. And for our calculations, we took this beam intensity here, the dotted line, which could be, in principle, at least theoretically, delivered with the cyclotron we have at our institute. Now, I say theoretically because actually we couldn't, or we can't do this at the moment due to safety regulations, monitoring issues, etc. So this is a theoretical exercise, but this is what the machine could deliver if we could get around or improve monitoring and put the necessary safety mechanisms in for delivering these high dose rate treatments. So we could do this on this case, and in this work, we looked at a number of different treatment scenarios, all using pencil beam scanned proton therapy. So on the top, you can see 4 plans, which I've called IMPT standard, IMPT spot reduced, which I will say what it is in a couple of slides' time. Spark, we also looked at arc therapy with protons. So this is using many beams around the patient, and this is the dose distribution you can see here. Spark is being developed, for instance, by IBA as a potential way of delivering proton therapy. And we also looked at this work in looking at what could we do if we used transmission. And by that, we mean just using the highest energy proton beams and shooting through. So in fact, with transmission, we're not using the Bragg peak, we're using the highest energy protons to shoot through. And the reason being, if I go to this slide, is we get the highest beam intensities at the highest energies. So if we actually treat with 230, which will shoot straight through the patient, we do actually achieve then the highest beam intensities. And this is what a arc treatment plan would look like with protons using 230 rotating around the patient. Doesn't look dissimilar to a VMAP plan, of course. So these were the 4 things we looked at, and then we could apply this dose average dose rate model, taking the dynamics of delivery beam intensity, etc., into account. So on the top is dose. On the bottom now is the dose rate in gray per second, the dose average dose rate at every point. So now you can see we have a spatially varying prediction of the dose rate at each voxel. And using the scale on the right, you can see that as we go from left to right, we're moving up and increasing the dose rate depending on the delivery scenario we're assuming. So this is what we call standard IMPT. These are the dose rates we could achieve on our machine at the moment using conventional delivery and conventional planning. You'll see these 3 are what we call spot reduced, and as we go from 4-field pencil beam scanning, IMPT, through to the Spark, and then particularly for the transmission, you can see with the transmission, we really achieve quite high dose average dose rates. And you can see we're up here in most areas above this 40 gray per second, which was the figure quoted in the paper by Fovedon. So this transmission looks an interesting technique. But also, just let's go from here to here. You can see that these are both IMPT plans. You can also see that the dose distributions for these are very similar, but we see quite different dose rates. And this is important. So how we deliver, how we plan, even if we get very similar dose distributions, can have a significant effect on the dose rate distribution. So you see the 3 plans on the right, we've said what we've done is spot reduction. And in fact, this is a technique, again, developed by Stephen van der Water during his PhD work in Rotterdam, which we've applied here. And this is just a method in the optimization to reduce the total number of pencil beams we need to deliver to get a clinical dose. So you can see the two dose distributions, top and bottom. This is typically how we do it, a dense grid of regularly spaced spots, but then adding a spot reduction algorithm into the optimizer, which is gradually throwing pencil beams away and randomly adding new ones, we can significantly reduce the number of Bragg peaks per field from a few thousand here to only a few hundred. Now, why is this important for flash? Well, by reducing the number of pencil beams, it means we increase the monitor units, or the number of protons required in each pencil beam. And by increasing the protons per pencil beam means that we've got higher monitor units, and there we can actually increase our beam intensity per pencil beam. So reducing the pencil beam number lets us deliver higher intensities per pencil beam. And this allows us to increase the dose rate in the plan. So this spot reduction, if you like, is a dose rate enhancer. And this is the dose rates, as I showed you before, with all the many pencil beams. And this is where we have significantly reduced number of pencil beams because we can increase the intensity of each pencil beam being delivered. So I just wanted to say this because all the subsequent results I will give are assuming we can do spot reduced IMPT. Now, I don't know anywhere in the world who actually deliver this clinically at the moment, but I'm sure it will come in the next 1 or 2 years. But just to indicate that these results are all based on spot reduction. So we've got now a method of generating a average dose rate. But is this enough for flash? Because obviously now we don't have a constant dose rate here, we have a spatially varying dose rate. Some points may see flash, some points may not get flash. So can we predict that? So we've also taken the next step, and this is work done by Miriam Krieger, but based on a model first proposed by Alejandro Mazal, actually at the PTCOG conference in Manchester back in 2019, and we've incorporated this model into our treatment planning system. So this now moves from dose rate to actually trying to predict a three-dimensional spatially varying flash effect distribution. And we just have this as a percentage. We will say, okay, the flash effect, if it comes in, is, let's say, a 30% effect. That means it reduces the normal tissue by about, the effect on the normal tissue by about 30%. So here it is. This is what we call the flash effectiveness factor, is the percentage reduction in biological effect due to flash. Now, just to quickly say the model, it's very, very high level and very, very phenomenological and just has a few parameters. So it's not trying in any way to capture the underlying biology. It's just at a very macroscopic level, trying to say, okay, what could happen if we have a flash effect? It makes no assumptions on biologically how the flash effect or what the flash mechanism is. So we basically say, okay, we need a dose rate threshold, clearly. So in our model, we just say any point, any voxel, which is being delivered at a dose rate more than that threshold, let's say 40 gray per second, we assume we'll have the flash effect. We also have a dose threshold, and there's evidence out there that flash will only be triggered if it's above a certain dose, even if it's delivered at the high dose rate. So if it's delivered at 40 gray per second or more, but the dose delivered is less than that threshold, we will not see a flash effect. And we've taken this to be about 5 gray in the model. We also assume that after a voxel has been flashed, let's say, and the flash effect has been triggered, that flash effect, that biological reduction, will persist for a certain time, regardless of what dose rate is applied afterwards. And that we set in the default to 200 milliseconds. And if all those things are considered, the dose applied at that voxel is then reduced by a flash effect we estimate here to be about 33%. So this is about 0.67. So this is the model. As I say, it makes no assumption from of the biological mechanism. It's basically giving us a model where we can see what the flash effect could do if it has a certain magnitude. Okay, so we've applied this to a number of cases, but I'll take one example. So we've taken a pancreas cancer case. We assume hypo, or in fact a single fraction, maybe not practical, but okay, that's what we've done. And we've taken a dose of 22.3 gray. We've taken the linear quadratic model and calculated the biologically effective dose if we treated a single fraction compared to if we compared in normal fractionation. We've looked at 6 different planning scenarios. I'll show you those in a minute. All spot reduced, remember, so this is really pushing on the dose rates to the higher levels. We've calculated this flash effectiveness ratio and then what we call the flash effect weighted dose, which is simply dose times this flash effect if the flash is triggered in a voxel. And then we've compared these to a reference clinical plan. So these are the 6 plans we've looked at. We've looked at conventional pencil beam scanned proton therapy, a single field plan, 2-field plan, and we've also looked at different ways of modulating the energy. Now, the one on the left is basically how nearly all proton machines work at the moment. The energy variation for the Bragg peak is done upstream, close to the accelerator or before the gantry. This affects intensity. By doing the energy modulation upstream, we lose energy as we decrease, we lose intensity as we decrease energy. We've also looked at the same beam angles and also pencil beam scanning, but now instead of upstream energy selection, assuming that the energy variation is done downstream with range shifters just before the patient. In fact, this is how we worked many years on gantry 1 at PSI, and essentially the Mevian machine does something similar to this now as well. The advantage potentially for flash there is we get better intensities. We don't lose so much intensity by doing downstream energy modulation. Then we also looked at this concept of transmission using the highest energy to treat through, shoot right through, to really utilize the highest beam intensities from our proton accelerator. And again, we looked at a single field, just shooting straight through, and then 7-field transmission plans. So these are all the physical doses for those different plans. We could then apply the model I showed in the slide before, and we can get these flash effectiveness factors. And these now pictures show you in color the flash effectiveness factor for each of these plans. And you can see the 2-field conventional pencil beam scanned has hardly any flash effect. Whereas we can go to the single field transmission plan and we get a large flash effect. We get a lesser flash effect with the 7 fields simply because the dose to the normal tissue where the fields are not overlapping, in many cases drops below the dose threshold we've implied, which remember is 5 gray. And then here we have now simply dose times that flash effectiveness factor. So these are now the flash weighted dose distributions, assuming the flash effectiveness distributions we see in the middle row. So we've got a lot of data here. We will compare these in a minute, but I just want to say we also compare these to our reference plan. This is the reference plan. We say, well, okay, if we're going to treat a pancreas with pencil beam scanning protons today with conventional fractionation, conventional delivery, we may do something like this. So anything we're doing with flash should give us a clinical advantage over this plan if flash is going to bring a clinical benefit. So let's try and quantify this. The first thing we looked at was, okay, not looking at OAR doses, let's just look at the total dose delivered to the normal tissue, the integral dose outside of the target volume. And we could compare the physical dose to the physical dose times the flash effectiveness we calculated with our model. So we can calculate this as a simple ratio, and this is the results we got. In the blue columns, these are the single field plans, and the red columns here are the multiple field plans. This is the ratio of integral dose, and this shows you the improvement, the reduction in integral dose, which could be achieved by going to flash. So if we look at the pencil beam scan plan upstream modulation, the flash is not as effective as the downstream modulation. And remember, because downstream modulation gives us a higher beam dose rate, the transmission is extremely effective. So the transmission really gets a high dose of flash effect and reduces the integral dose actually by the maximum amount, which in our model is around about 33%. We see less of an effect when we go to the multiple beams. Remember again, because I said multiple beams, the dose to the normal tissue, even going to 22 gray, single fraction, a lot of the voxels simply see a dose below the 5 gray, which we have as the dose threshold for the flash effect in our model. So as we go to multiple beams, we can already see the flash effect compared to the physical dose alone is less effective. We also looked at clinical benefit. Now, this is the plan we would now deliver. Let's say not taking any flash effect into account. This is the sort of physical dose, well, multiplied by 1.1 for RBE. And then this is now a flash weighted dose for a transmission beam. And we can compare the integral dose here to here to see if we see any clinical effect. And now the results look quite different. So now if any of these bars is below 0, negative, we're showing that the plan is worse than our clinical standard. So if we look at the single field plans, there's only one plan where potentially flash, at least in this model, would give an advantage. And that's the pencil beam scanning with upstream modulation, which is odd because that actually has the worst flash effect. However, the reason is it gives us much better dose confirmation. So the dose to the normal tissues is reduced significantly or substantially or enough that in fact it more than compensates for its lack of flash. The converse is true with the transmission plan where we get a high flash effect, but the dose confirmation, the total dose to the normal tissue is a lot higher. The integral dose is higher because we have a lack of dose confirmation. So when we do this comparison, the transmission plans don't come out so well. Now, that was just one case. We looked at this at 10 different cases. You can see them just summarized on the left, and you can see the results are very similar in over all cases. The only plans here which would show for the clinical benefit, remember, compared to the plan, when we take this flash modeling into account, is for some cases is when we do this with our conventional delivery with spot reduction, but also assuming that we can get to the highest intensities our cyclotron can deliver. As soon as we go to the multiple field plans, we're finding it's very difficult to find any clinical advantage from the flash effect when we're looking at all the normal tissues. Now, of course, this is a model and it has some parameters, and let's face it, none of us really know what these parameters are. These are the assumptions we made here for these cases: 5 gray dose threshold, 40 gray per second dose rate threshold, a persistence time of 200 milliseconds. So how sensitive are these distributions or these plans on these parameters? Well, we looked at that as well. These are some plots of how this clinical benefit varies as a function of fraction dose. The threshold dose, we took 5 in what I showed before, but we varied it between close to 0 to 25. We looked at the threshold dose rate. We looked at the persistence time. And these bands now are just over all the 10 cases. Let's say we just take the median values, then we can see now that as the number of fractions increases, this is 1 fraction going to 10 fractions, or conversely, as the fraction dose increases, of course, we're getting some improvement in the clinical benefit, but on average, the one field IMPT plan, PBS, or the one field transmission, always we're giving worse clinical outcomes than the conventional plan. If we look at the threshold dose, you can see also as the threshold dose increases, as you would expect, we get less and less flash effect. If it goes below 5, though, you can see here, at least for the PBS plan, we start getting into the positive range where flash could give us a clinical benefit over the clinical plan. Threshold dose rate, we were less sensitive on, and actually persistence time, we found virtually no variation at time, at least over the range of values we were looking at. So then we took a step further, and this is some very recent work done by Stephen, where we look at flash against fractionation. So if we look at this plot here, you can see that basically, if we're going to exploit the flash effect, we are going to have to use small fraction numbers and high fraction doses. So this means to use flash, we're going to maybe have to abandon fractionation. So how does the flash effect compare to fractionation? So we took this clinical plan. This is the physical dose. And we now assume that the alpha beta in the tumor is 10 and the alpha beta in the normal tissue is 2. And of course, then we can calculate biologically effective dose, taking the conventional fraction, which in this case was 30 by 2 gray, into account. We could then plot very theoretically, or calculate very theoretically, what would be the flash effectiveness factor we need to be able to compensate for the lack of fractionation if we go to hyperfractionated treatments. And that's this plot here. So if we go to a single fraction and we're looking at doses, normal tissue doses, which get 80%, which is this point here, we need a flash effectiveness factor of around about 0.67. So a reduction due to flash of about 30%. So that's what we'd need here to get that dose to be comparable or compensate for a lack of fractionation when going for a single fraction treatment. Now, actually, as it turns out, this single field transmission plan I showed you before, this gives us, at least within the parameters of our model, about that value. It gives us this 30% reduction. So in fact, here, this plan would, the flash effect would potentially compensate for not using fractionation, which is sort of good news. But remember, of course, that that transmission plan has a much higher integral dose. And if we calculate it here, it's nearly 2 times higher total dose to all the normal tissues. So if we factor that in as well, we can actually see that even in this case, we may not get enough flash effect to compensate for fractionation and the lack of confirmation that such a technique, such as a single field transmission beam, would deliver. And I think this is an important take-home message. Okay, but there may be other areas. And there was a question to Marie Cataran before about, is flash an effect which may be best close to the tumor? Now, interestingly, we had the same idea, and that's what we've looked at. So we also looked, and this is in a paper in MedPhys, which is currently in review, we looked at just the margin from GTV to PTV for all those cases. Our argumentation here is that is an area by definition which is a mixture of tumor cells and normal cells. If there's a therapeutic ratio of flash, i.e. it's effective on normal tissue, but not effective on tumor tissue, then actually its main benefit could be in this margin where it's a indistinguishable mixture of tumor and normal cells. So we did this, and again, we looked at the 2 field plans, and there we do find that actually looking at the multiple field plans, we could see maybe a 10% reduction in biological effect on the normal tissues in the PTV margin. And if we look at the single field plans, up to 30% just in this margin area. So there could definitely be potentially an advantage of flash in that area between the GTV and PTV, which is a mixture of normal and tumor tissues. And we did that for all the cases you can see here. And again, the results are more or less similar, that if we look at that margin, this is where potentially an area, a volume or an area where flash could really be very effective. So just to summarize, treatment planning simulations, I believe, can outline the challenges ahead, even if these figures we have in this very phenomenological model are uncertain. I think it can show us what we're going to have to work to at the very highest level from our delivery. An important parameter is definitely the dose threshold. If that's too high, we're simply never going to get the dose in the normal tissues to trigger the flash effect. And I think it's a very interesting, important parameter to be looked at preclinically to see at what is the flash effect for different the dose threshold for different organs. Flash will definitely, in my opinion, only be effective if combined with dose confirmation. So we need to be able to conform the dose and get the flash effect. And that's the challenge to all of us for being able to exploit it, I believe. But flash could potentially be effective in this GTV-PTV margin, which is a mixture of normal and tumor tissue, where we have high doses and where, of course, we can also have the highest dose rates. So that could really be an interesting area to focus on from the clinical point of view for exploiting the flash effect. And with that, I see the chair people have switched on, telling me to shut up, so I will, and I'll leave it open to questions. Thank you very much.
Tony, thank you so much. That was absolutely great. I'm going to hand over to Mike to start the questions off. So, Mike, over to you.
Okay, great. Thanks, Tony. So we've got quite a few questions, actually. We've had 16 questions, but we'll just go through the most. We've got time for a couple. So we go for the most voted question, which is, what are the major beam parameters optimized for flash treatment planning compared to conventional treatment planning?
think that's well, it's a very interesting one. I think it gets back to MCAT's talk earlier and a little bit. I mean, it's first we need to understand what mechanism and what beam characteristics we need. Is it the dose rate averaged over the whole field? Is it the dose rate averaged over a segment? Is it the dose within a pulse if you've got a pulse machine? We simply don't know that yet. But certainly we are going to have to take those parameters into the treatment planning system to be able to predict it. So if it's dose per pulse, we need to be able to model the dose per pulse or the dose rate per pulse spatially so we can see where it is. Obviously, for pencil beam scanning, one of the big parameters will be the energy change time, because that's the slowest. Is that going to be too slow to get the dose rates as MCAT showed before? It's maybe a combination of the dose rate in the pulse plus total treatment time, although I wonder how that can be, but that's a different question. So if we really want to also have to reduce the total treatment time with protons, we may really have to work on energy variation. And that's why a lot of people, including ourselves, but some people have already shown experimentally that using ridge filters, so you deliver a full SOPP without any energy changes, could be the way forward to get to the dose rates you need for protons and still get the confirmation required to get both confirmation and exploit the flash effect. So I hope that's sort of answered the question.
Okay, and the next question. The model makes no assumption on the irradiated volume necessary to see the flash effect. You want to comment on volume?
Oh, well, okay, let me just see if I interpret it. The model works at the voxel level, you're right. It doesn't make any, it doesn't make any assumption on the volume effect. If the volume effect you're asking about is the volume effect from NTCP model type point of view, then I believe it could be used, because if we take the dose times the flash effectiveness factor, we get a flash weighted dose, which essentially in principle we could put into the NTCP models, although that's a very, very big question mark if things are still valid. So if that's what the question was pointing for, that's what I think we would need to do.
We have time for one more, or
go for one more.
One more, okay, so one more question. So when using transmission, you don't use the Bragg peak and thus have potentially lower RBE. Did you try to include this in your models?
No, we didn't. It's a good point. I think the RBE is going to be closer to 1.1, potentially less than 1.1 in the transmission exactly. But I think within the error bars of the model anyway for flash, the RBE is probably below the noise level of the uncertainty in the flash parameters. It's an excellent point, and at some point we would need to maybe look into it. But I think, you know, these where the dose, well, even our model assumes that it's a real sharp threshold. You know, 5.1 gray gives you flash, 4.9 doesn't, and that's unlikely to be true either. It's probably going to be some sort of smoother transitions. There's a lot of things where we could improve and refine the model before probably it's even worth thinking about RBE affecting it.
Thank you, Tony. I think we're going to have to stop now because we're going into the coffee break. What I would encourage people, well, first of all, thank you so much, Tony, and I think you'll be getting virtual applause. The next bit is that we will be going into a coffee break. What I'd also encourage people to do is there is a networking area. If some of our speakers are going to be in the networking area at some point today, there's an opportunity to talk to them there, or to form your own networks, or to invite people to talk to you. So please use that, and please keep asking the questions. And I'm sorry we didn't manage to answer them all, but I'm sure they'll get answered during the meeting. Thank you all so much. And I think you've now got a coffee break. Thank you, Tony.
Thank you. Bye-bye.
Bye.